Good afternoon. Thank you for joining us for our Cancer Conversation series brought to you by UNC Lineberger Comprehensive Cancer Center. My name is Jennifer Potter and I will be your moderator today. Today's presentation will be all about understanding breast cancer. Timely topic given that October is known as National Breast Cancer Awareness Month. We're delighted to have Dr. Crystalline Gallagher with us today. Dr. Gallagher is the surgical director of our breast cancer program. So without further ado, I'll turn it over to Dr. Gallagher.
Thank you. So yes, this is a very important topic and very near to my heart, so I'm delighted to be here. Today is going to be really talking mostly about understanding breast cancer. It'll be very basic, but just a general overview of what breast cancer is, what treatment modalities, and feel free to email us and send in your questions so we can answer those at the end. The overall objectives, breast cancer basics, so we'll talk a little bit about anatomy, how to find or screen breast cancer, signs and symptoms that you should look for when you're screening for breast cancer, factors that can increase your risk, and then finally how to manage your fears. No one ever wants to hear the words that they are diagnosed with breast cancer. That can be very scary, and so really kind of managing that is very important. I tell the story sometimes to one of my patients came in and they were terrified because they were being diagnosed with the big C. It is very scary, and so really kind of looking at what breast cancer is and really understanding your diagnosis is very important. How common is breast cancer? 1 in 8 women are affected by breast cancer. Your lifetime risk is 12%, and that's outside of a family history. If you have a strong family history or a genetic predisposition, so sometimes women have multiple members in the family, and there's a gene that's responsible for that, that's passed from mother to daughter or from father to daughter or mother to son, that puts you at a much higher risk of developing breast cancer. But in general, without that genetic predisposition is what we call it, your lifetime risk is about 12%. So the breast, just a little bit of general anatomy. The breast, so you have 2 breasts and they are very separate organs. So one question that I commonly get is, will my breast cancer in my right breast go to my breast cancer or go to breast cancer in my left breast? And typically the answer is no. They are very separate organs. The breast is an organ in the body and it has many different elements that make up the breast tissue. As we get older, so when we're younger, our breasts are very dense and firm, and they're mostly structural elements or kind of ductal tissue. As we get older, our breast becomes more fatty replaced, and that's what causes that loss of volume and kind of sagging of the breast over time. Most of your breast tissue is in that upper outer portion of the breast, and so many cancers are kind of, if you're looking at your breast towards your armpit, in the upper outer quadrant. The breast is made up of, in addition to fat, milk ducts and lobules. Lobules, you can see here, and I'll highlight it on the picture. Lobules, there are about 15 to 20 in the glandular tissue of the breast, and they're arranged kind of like petals on a daisy. Each of the lobules have a very intricate network of structures or tubes called milk ducts that attach it, and they basically run from those lobules up to the nipple. This is important whenever the breast undergoes full maturation or when it fully develops during pregnancy. So during pregnancy, these lobules are responsible for that milk production, and this tubing system, the ducts, the milk ducts, take that breast milk from the lobules up to the nipple, and that's how the baby will nurse. So this intricate ductal system or tubing system is really important. When you're talking about breast cancer, cancer can form in either of these locations. Breast cancer can form based on those lobules, but it can also form in the milk ducts, and that's kind of where you get the different types of breast cancer, ductal breast cancer and lobular breast cancer. We're going to talk in more specific details a little bit later. But basically, these milk ducts go all through the breast, and if it's in the duct, it's ductal, and if it starts or originates from the lobules, it's more of a lobular breast cancer. So these are types of breast cancer. Ductal carcinoma in situ, or DCIS, are these abnormal cells that start in that milk tube system or duct system. And I'm going to talk about that here in a moment and the difference between a DCIS or ductal carcinoma in situ versus an invasive cancer, because these are very different entities. The most common invasive cancer is a ductal, an invasive ductal carcinoma. Second is an invasive lobular carcinoma. And again, we talked about that because whether it starts in the duct system or whether it starts in the lobules are kind of the different areas that it can start. Inflammatory breast cancer is something that will actually cause inflammatory changes or swelling and redness to the breast itself. And so that's a little bit different, and we treat that a little different because it tends to be more aggressive. But those are the basic types of breast cancer most commonly that you will see. So ductal versus lobular cancers, we talked again. So this is a different picture of the breast. This time you're looking at the breast if it's cut in half. So here's the nipple here, those ducts that are going right up to the nipple, and then the lobules that are back here. If the cancer cells are formed within that ductal structure, then you get a ductal cancer. Now, there is something called DCIS, or ductal carcinoma in situ, and what that is, it's cancer cells, but they're contained in that tube itself, in the milk duct, or in that tube structure. This is very early. If those cancer cells break through the wall of the duct or the tube and invade the surrounding structures, that's what makes it an invasive cancer. And the importance of that is when those break through the wall, then you have blood vessels and lymphatics that live outside of that tube structure, that milk duct. And the cancer cells have access to the blood vessels and the lymphatics. The reason that's important is that's the highway that cancer can spread to other areas in the body. Typically, the first place it'll go would be to the lymph nodes under the arm, but it can go to other places, really anywhere in the body. And so that's that highway that it travels to get there. If you have the early breast cancer cells, or ductal carcinoma in situ, you can see that there's no way for those cancer cells to have access to that. So this is the earliest form of breast cancer that we have, something called a stage 0, and by definition, as long as it's contained in that tube, then there's no way for cells to send cancer cells elsewhere in the body. So that's a little bit about invasive versus in situ cancers. So when we get a breast cancer diagnosis, things that we specifically look at are receptors or characteristics of the cancer itself. There are 3 primary receptors that we look at: estrogen receptor, progesterone receptor, and HER2/neu, which is actually a growth factor on the tumor. The best way I can think of to describe these different receptors, so I think everyone knows how to play a movie on TV, and whenever you're playing a movie, you can pause, you can fast forward, or you can rewind. Generally speaking, we want our cells to be on the pause mode. Receptors are kind of like our remote control. When those receptors get pushed, then you can actually push play or fast forward and start cell growth. So you can see down here we have a breast cancer cell. We have these receptors that live on the cells, and we have hormones that normally float in our body, estrogens and progesterones. And as those estrogens and progesterones attach to those receptors, basically it's like pushing the button on the remote and you go from pause to play. HER2 is a receptor specifically on the tumor that basically it's a growth factor. So this is like if this gets activated, it's like pushing the fast forward button. And so these are very important when you're looking at breast cancer, because what we want to do is we want to see if we can target those receptors and turn them off or push stop, sometimes even push rewind. And so that's what medications can do, and we'll talk about that here in just a moment. So how to detect breast cancer? The best way to detect a breast cancer is with a mammogram. There are different guidelines related to when women should start having screening mammograms. A general rule of thumb is your first mammogram should be around age 40. After that, you should talk to your doctor about what your risk is to see if you would benefit from a mammogram every year or if you should wait till age 45 to start mammograms once a year. At age 45, that's when most of the different committees that kind of get together and make these recommendations recommend for women to start having mammograms once a year for screening. The other question that comes up is you have been doing your mammograms faithfully. Is there a time when you can stop doing mammograms, or maybe not every year? Can we space it out and go to every other year? Most committees recommend that at age 55 to 60, I misspoke. At age 70, you could consider going to every other year. But between age 45 and age 70, you should probably be having a mammogram once a year. There are certain situations and circumstances that your provider may recommend spacing it out during that time, but in general, that's a good rule of thumb. High-risk breast screening. So we talked a little bit about patients who are higher risk, whether it's a family history or whether they have a gene that runs in the family. This screening is a little different. It's more frequent than once a year. Usually for high-risk patients, we recommend having both mammograms and MRIs, and we rotate those so that it's one every 6 months. So a mammogram with an exam, and then 6 months later an MRI. MRIs are very good to look at the breast tissue. Unfortunately, they're also very sensitive, which means they pick up things that probably aren't anything. That's the reason we don't screen with MRIs, because many women would get unnecessary biopsies. So mammograms really are the best tool to screen with unless you have a much higher risk than the average population. Self-breast exams are also very good. There are differing opinions as far as whether or not to recommend women do self-breast exams. I do recommend for my patients to do a self-breast exam. The reason for the difference in opinions is that when you do a self-breast exam, women are going to find lumps, especially the first few times you do it if you don't know your body. As you get to know what your breast feels like, that's really where self-breast exams help, because you know your natural lumps and bumps, and when things start to change or grow, you can tell your doctor. So the best way to do a breast exam, there are many ways to do it. The best way, though, is to do it both standing and laying. I typically tell my patients to do it while they're in the shower because they're washing their body anyway and everything is a little soapy and it's easier to feel things. You can, the best way to do it is to use the palm of your finger, kind of the pad of your finger rather than the tip, so that you can feel more of your breast tissue. You can do it from outside towards the nipple all the way around, kind of like spokes on a wheel. So you start on the outside and you work your way to the nipple and you just kind of go all the way around the clock. Another way to do this is to start on one side of the breast and go up and down, so that you start on the inner side and get all the way to the outside. And then the last way is you can start at the nipple and then go around in a circle until you cover all of the breast. Any of those ways are completely fine as long as you're actually feeling all of the breast tissue. One of the things I tell my patients as well is you want to feel up into the armpit, because that breast tissue actually extends all the way up into the armpit. So you want to feel that area. And lymph nodes live under the arm here. So any lumps or bumps under the arm that are new or changing, you should tell your doctor. So what to look for on breast exam? So the first thing is, look in the mirror, see what your breast looks like. As you move your arms, do you notice any changes? Is the skin red? Is it hot? Do you have an infection? Those are things you want to talk to your doctor. If the skin becomes red or really thickened and it's not getting better with antibiotics, you should also see your doctor for that, because that's a type of breast cancer sometimes that can involve the skin. We look for discharge from the nipple, so if the nipple is leaking, that is a problem, especially when you're not stimulating it and it just happens in your bra. If it gets more frequent or worsens, then you need to see your doctor for any kind of nipple discharge. Discharge can be normal sometimes, but it can also be abnormal, and so seeing a healthcare professional to differentiate what is normal and what's not is important. Finally, as you kind of move, especially your arms, if you raise your arms up and lower them down, if there's something underneath in that breast tissue, it pushes on that support structure in the breast and it can cause skin dimpling or puckering. That's abnormal. That's something you should follow up with your doctor about. And then finally, just looking at the appearance of the nipple. Nipples should be upright. They should stay the same. And everyone has different breasts and everyone has different nipples. But looking and knowing what your nipple looks like, if you see changes, that's what's really important. If the nipple suddenly becomes sunken in or starts pointing one way or the other, that's something that needs to be addressed. So after you're diagnosed with a breast cancer, there are different ways to do this, but typically a woman will present with a palpable mass or an abnormality on their mammogram. You're going to get a breast biopsy, and I don't have a slide showing you a picture of this, but the way they do a breast biopsy is generally with a needle, and they'll numb up the skin, they'll put the needle in the breast, and they get tissue. Signs and symptoms of breast cancer are different than a diagnosis of breast cancer. So things that show up as a lump or a bump or abnormal on mammogram should always be diagnosed or should always be biopsied so that we actually get tissue and we know what's causing it. Because other things that are not cancer can also cause some of these changes. So that's really important. Once you're diagnosed with a breast cancer, there are multiple modalities that we use to treat breast cancer. The three are surgery, radiation, and then medications. These can be done in different orders. A lot of it depends on what your specific breast cancer is and what your treatment plan is. Surgery is divided into two types: a lumpectomy, also known as a partial mastectomy, where we remove the cancer itself but leave the rest of the breast, so removing part of the breast but leaving the rest of the breast. Many of my patients get nervous when they see the word mastectomy. Lumpectomy is kind of a common term, but a partial or a segmental mastectomy is the more medical term, so that's not something to be worried about. It's just removing the part of the breast with the cancer. The other option is a mastectomy, or removing the entire breast, and there are different ways that we can do that. Finally, sampling the lymph nodes is important. Usually that's done with what's called a sentinel lymph node procedure, where we take out that first draining lymph node. But for some women that have known lymph nodes, or have lymph nodes that we know have cancer, we have to remove even more lymph nodes. Radiation is important, especially when women have a lumpectomy, because with that procedure we save a lot of the breast, and so it's important to radiate the rest of the breast to reduce the risk of it coming back in that breast. And then finally, medications such as chemotherapy, hormone blockers or pills, and targeted medications. If you remember back to when we talked about those receptors, these medications can actually go in and block those receptors to put the cancer cell back on pause, or sometimes even rewind. For this reason, we use medications up front before surgery first, sometimes, depending on what type of cancer you have. And this will help us to actually make the cancer shrink or get smaller. That helps make you a better surgical candidate. And so it depends on the type of cancer which one of these modalities will go first. And then finally, targeted medications, which are that specific targets. We talked briefly about the HER2, which is like a fast forward button for breast cancer. Some of these more targeted therapies can go in and block those receptors as well. So these are important considerations. So what about risk? What actually will reduce my breast cancer risk? Being female is number one. Unfortunately, we ladies have much more breast tissue, usually, than our male colleagues, but being female is the greatest risk factor. As we get older, kind of our spell checkers that we all have get a little rustier, and so things get missed. And so as we get older, we're more likely to form breast cancers, just spontaneous, out of the blue, for no other reason. It's not related to family or genetics or anything like that. A genetic predisposition or a family history does put you at increased risk. The more dense your breasts are, the more tissue you have, more kind of ducts and lobules, you're at higher risk of getting a breast cancer. And then hormone replacement therapy. So we talked about the hormone blockers. If you're taking hormone replacement, basically if you formed a breast cancer, that gives you additional access for those cells to go on play or fast forward. And so the longer that you're on hormone replacement therapy, the higher your risk is for developing a future breast cancer. And then obesity. So even after we go through menopause, before menopause, our ovaries are the primary source of estrogens. But after menopause, our body still continues to make estrogens and progesterones, and that's primarily done through our fat cells. So the more fat cells we have, the more circulating estrogens we have. So obesity is another risk factor. So kind of going back to healthy ways to manage your stress and fears, the best way is to have a good support system at home. And this many times is family, spouses, significant others, but also for women who don't have the support system, having a social network. So friends, church, community, someone that can be there that you can call on and talk to, bounce ideas with. I try to encourage all of my patients to bring someone with them to their clinic appointments because it's really good to have a second set of ears so that you can sit and hear what's being said. When you're going through your first or second hospital visit, it's really difficult to understand and absorb all of the information because it's all new. So having someone there that can help remind you and help you answer questions is important. Mindfulness is a concept that's really kind of becoming more and more popular, but really it's kind of thinking about your situation and reminding yourself and redirecting your thoughts. And so when you hear the word cancer, it's very anxiety provoking. You're worried, you're not sure, you're jumping 5 years ahead. Am I going to be here for my family, for my kids? And so sitting in those clinic visits and understanding that diagnosis and then having a treatment plan so it's one step at a time, I think is really important. And that way you kind of focus all of your energy on the next step. So the first step, I know I have cancer. The second step, if your treatment plan is surgery, we're going to talk about the surgery and we're going to take care of it. And then we're going to think about radiation, and then we're going to think about a hormone blocker pill. So one step at a time, I think, really helps to focus those energies. Mindfulness, reminding yourself of what else is going on, is also important. So yes, you may have a breast cancer, but what else is going on in your life? Are there other things you can focus on and be thankful for? Do you have a family? Do you have a good support system? Do you have friends that care about you? So really kind of reframing, I'm here, I'm going to get through this, and kind of reworking that positive energy, I think, is helpful if you can. Yoga and exercise are another way that you can do that. We know that with exercise, our body produces normal positive endorphins, and so our brain is much happier. So if you can get on a good exercise routine, that is very helpful as well. But I think really going back to that first bullet, having that good support system, family, friends that you can talk to is really the most important thing that you can do. All right. This time I think we're ready for questions.
Thank you, Dr. Gallagher, for that wonderful presentation. I'm sure our audience appreciates all the knowledge you have to share. Just since we have enough time for a couple of questions, I wondered, you probably run into women all the time who are fearful of getting screened. They're fearful of learning whether or not they actually do have cancer or don't have cancer. So what would you say to viewers today who might be scared to get a mammogram?
So really, knowledge is power. I tell my patients this. It's really important that we can catch things early, and studies have shown that with mammography we can actually catch breast cancers about 2 years before you could feel a palpable mass. Now, of course, that's not the same for all cancers, but in general. And so having a mammogram and finding cancer early when it's still small really opens what treatment options you have, and it gives you a much better prognosis. So I would really encourage women to continue with their screening mammograms.
Thank you for that. And is there also just something we can do every day to decrease our risk, be it nutrition, physical activity? Is there anything that you recommend to women?
Absolutely. So a good healthy diet and exercise regimen is key. Sometimes it doesn't matter what you do. You can do all the right things and still have a breast cancer, but we talked about, the obesity link, and so maintaining a good normal weight and having an exercise and a good diet balance is important.
Thank you. Thank you. Well, that concludes our conversation for today. I want to thank Dr. Gallagher for her time and for all the knowledge she shared with us today. Please join us next month when we learn more about vaping and lung cancer. That conversation will take place on Friday, November 30th at 1 p.m., and we will see you then. Thank you.